and welcome to Every Life Counts. Now, India has the largest population of adolescents in the world. That's equivalent to the combined populations of Japan, Germany and Spain. By 2020, the average age in India will be 29, and we're set to become the world's youngest country with 64% of our population in the working age group. Now, this demographic can be a huge advantage. But is India doing enough to ensure that our adolescents become productive adults? Among adolescents, almost 47% of girls and 58% of boys are underweight in India, which is the highest in the world. A total of 56% of girls and 30% of boys in this age group are anemic. That's on par with some of the world's least developed African nations. Now, the healthcare sector clearly is where India must up its game. Rates of malnutrition among Indian children are almost 5 times higher than China, twice those in sub-Saharan Africa. A staggering 75% of new mothers are anemic. So will India's youth be a blessing or a curse, a demographic dividend or a disaster? Can India empower its huge youth population to bring about transformational changes to ensure economic growth, progress, prosperity and peace? This will involve providing the right education, vocational skills, social and moral values. But first and foremost, the basic foundation needs to be strong. They need to be healthy individuals. We have in studio today, we have Dr. Ajay Khera, Deputy Commissioner of the National Ministry of Health and Family Welfare. We have Dr. Sudarshan of the Karuna Trust, which works with creating successful private-public partnership models with governments and corporates to strengthen primary healthcare. We have Dr. Sunil Mehra. He's the Executive Director of the Mamta Health Institute for Mother and Child, and Dr. Monica Arora. She's with PHFI, that's the Public Health Foundation of India. She is an additional professor there. So thank you so much. First and foremost, Dr. Khera, how healthy you are as an adolescent will determine how healthy you are as an adult. Yet, we only see adolescent health as part of a national program as late as 3 years ago. That means we have a lot of catching up to do.
2014, we launched a big program which is called as the Rashtriya Kishore Swasth Karyakram.
Correct.
But before that also there have been efforts in terms of addressing issues around adolescent health. But at that point of time, the focus was a kind of a facility-based approach. That means establishing adolescent-friendly health clinic. But now for the last 3 years, looking at the problem of adolescent, the government of India has come up with a very big umbrella program, which not only addresses the so-called the nutrition or sexual and the reproductive health needs of adolescent, it also goes beyond that. It also talks about mental health issues. It also talks about drug abuse. It also talks about violence. It also talks about injuries and so on and so forth. So now I think that the program is well established.
So these are the main focus areas.
Yeah.
Particular pertaining to adolescents.
Yes.
So was there a turning point, a watershed moment? Why do you think it took so long? Why did we suddenly wake up to the fact? Is there something different about our youth today? Are we more urbanized?
Always as a policy maker or as a health planner, there are always priorities. Frankly speaking, let's say 10 years back, the priorities were, the health of mother and children. We wanted health. Let's
bring in Mamta here. So if you want to focus, let's say, on mothers and children, you need to bring in society, right? You can't just work with the individual. For example, I don't even have a choice often if I'm in a rural area, even in urban areas, about when I can get married. That decision is taken for me, and then, whether I have to have a child or not have a child, even that decision is not in my hands.
Adolescent in India is home-based. He is not moved out of house. Correct. He is in a family context, he is in a commune context, and he is in a societal context at large. So when we invest into adolescent, we must see that we do invest in the ecosystem that adolescent exists in, and that's what it makes it a bit more complex. In India, you cannot go to a services if you're less than 18, you need a parental consent. Now this is a big policy barrier for adolescent access. So what do you do if a girl child at 17 has had an unprotected sex last night and wants to access emergency contraception next day morning? She cannot, unless and until she brings her parents into the picture, which she will never do. What happens then, she goes to a quack, or sorry to use that word, to a non-qualified provider and gets into the big health risk. So we have created a setting by which this girl will not be able to access services by making this law. Whereas in many countries now, people say it is in the best interest of adolescents that services need to be provided rather than becoming a barrier.
India is changing. Clearly, our youth are becoming more sexually active than in the past. At the same time, like we said, for many young youth, their decision on when they're married or when they become sexually active is not theirs in the first place. So we need policy changes too. And we've mentioned women, girls. What about the boys? What about educating the boys when it comes to sexual habits?
36% of boys are anemic, which means every second is girl, but every third is a boy. So in the end, we need to talk about adolescent, where girls do need extra investment, but boys need significant investment. And
so
this will change the dynamics a lot.
Angle when it comes to adolescent health, right? So when we talk about, we have, as we've all agreed, we've been talking about the problems that face the girl child, the mother, much more than the men, the boys. Are there any specific issues or crises that affect adolescent boys?
No, both adolescent boys and girls, it all depends on how the overall healthcare system is functioning. So the anemia, as I said, is a major problem for both boys and girls, and it's a national shame. After 70 years of independence, the anemia control program is the simplest program which can be implemented. Now you have said tuberculosis free, but why can't we declare anemia free India? That's a top priority, which is something achievable, but we are not done. We have PET scans and MRIs, a simple tool for testing anemia, should not cost 5 rupees, but even that gadget is not given to the health workers, so that every adolescent person is tested for anemia and treated immediately. We need real missions which can take it and really bring about changes and do something for the adolescent.
It all boils down to priorities, as Doctor said here. But Dr. Monica, then put this again in perspective for us. Again, you know, we're in an urban setting here. We're in Delhi, the most cosmopolitan city in our country, amongst the most cosmopolitan cities. But what is the picture then in rural areas? If it's this bad in urban areas, what is it like in rural India?
There are needs both for rural adolescents as well as urban adolescents. And when we talk about health issues, right from physical health to mental health, needs are same, but it may differ that, for example, if nutrition or malnutrition is a problem in the rural areas, overweight and obesity may be a problem coming up in the urban areas. Yeah. We are moving what we now call the double burden of disease. It's now the triple burden of disease that India is seeing. We have overcome infectious diseases, but we have entered into non-communicable diseases. We are number 2 in the world for diabetes. Cardiovascular disease is a huge toll on our economy. So all these are lifestyle related. They need to start changing their behaviors before they start making their choices, which means interventions have to start before the age of 10. That's where they start making their choices. Behavior gets etched. So if they are already unhealthy in their adolescence, they will be unhealthy adults. They have started using tobacco as adolescents just because of peer pressure or out of curiosity to experiment. Even a single cigarette can be addictive. They become lifelong users of tobacco. So all boils down to having a healthy childhood, having a healthy adolescence period to be able to have healthy adults. And mental health issues, as we talked about, so mental health issues in the urban areas would be related to academic stress, anxiety, depression, but similar stress, anxiety and depression is there among rural adolescents as well, maybe for different reasons. So it's a vicious cycle of child marriage leading to illiteracy, and that would be for boys and girls. Once a girl gets married, she would quit school, but the responsibility is also on the boy. This boy may also quit school. So it's a vicious cycle of illiteracy, poverty, unhealthy, not seeking services, and we go on and on.
So we should get to mental health also, which we will, but staying with the sexual health, Dr. Khera, you know, when there are no schools in rural areas, then how do we even talk about classes on sexual health or sexual identity or just exploring, which all adolescents do?
You know, to be very frank, I mean, the scenario has changed in the last, I'll say, last 20 years. Why I'm saying is, like, you know, we look at the adolescent in particular, like around 10 years back, the out of school children, out of school adolescent used to be more than 70%. That means by the time they become adolescent, they used to quit schools. It used to be 70%. Now, if you look at the present data sets, it says around 38–40%. Still quit, but that means we have moved down from 70 to 40%. That means 60% adolescents are in the schools. So that means
that's only because the parents really want more than anything to get their kids in education so that they don't have the lives that the parents do.
So 60% adolescents are in schools. That's why we are trying to make best use of the school health platform to provide all prevention and promotion efforts around adolescent.
Even in rural areas?
Even in rural areas. I am talking about rural areas only. I am talking about
separate,
country as a whole,
Do you tailor, is your program tailored separately for rural areas and urban areas? Because
Absolutely.
I'm assuming what you're teaching in an urban classroom, you can't be saying the same in a rural classroom.
Even the state-wise also there are differentials. Like for state of Bihar, the kind of the curriculum will be a little different than the state of Kerala, because their level of understanding is different. So we have come up as a government of India. That's why I was referring to a program which is called as the Rashtriya Kishore Swasth Karikram, where we are trying to address the issue, we call it continuum of care. We have created dedicated facilities called as the adolescent friendly health clinics, and they are around 7,000 odd in number. At every block level there is a clinic where there is a dedicated counselor is available, dedicated doctor is there, but the only thing is people are not aware, people are not using the facilities, because generally people have a mindset that if they have a medical problem only they will go to a hospital. But because these adolescent friendly health clinics, they are in a health setting, they feel stigmatized. If I have to ask some questions, if I have to use, I have to take, contraceptive, let's say, there will be a kind of a stigma, people don't feel comfortable. But the government of India has tried to provide that kind of environment.
Dr. Mehra, you wanted to come in. Go ahead.
You cannot have reproductive health without sexuality. You rightly use the word sexual orientations. Sexual orientations begin in adolescent. Let me give you in HIV, the only age group where the HIV rate hasn't gone down is in the adolescent age group, because adolescent key populations, that is those who are using drugs or who have same-sex partners or who are into selling sex, begin in adolescence. If you don't intervene here, you are then treating only. You are not preventing, because you need to intervene between 10 to 14 to stop the initiation of certain high-risk behaviors.
Absolutely.
This is not to change sexual orientations. It's to say you can choose your orientation, but you need to be safe. And this needs to be done much early in life. They will not come to clinics for this, I'm sorry. They will need these services either in school or in home-based interventions. This cannot be done in the clinics. No adolescent will go to a clinic to say, I have same-sex partner. Nobody. So hence we need to do it in either in their safe environment, and their safe environments are
That's
either
a really
school
good
setting,
point, because how many adolescents can, your parents will ask you before you leave, where are you going, beta, where are you going? So
it has to
okay,
be
so
these
let's take a quick break. Let's come back. Adolescents, young people between the ages of 10 and 19, that's what we're talking about. When you think of them, you think this is a healthy group. Is that true? More coming up after the break.